Good afternoon. My name is Mary Burkhardt, and I am here as one of the presenters today, along with my colleague Nicole Mollenkopf, and we are going to discuss teaching a systems approach to medication safety improvement. My background is I'm a hospital pharmacist by trade, and I work as a medication safety expert over probably the last 25 years. And I met Nicole when she was a second year resident, and she did a rotation at the agency where I work. Nicole?
Thank you, Mary. So my name's Nicole Mollenkopf. I am a pharmacist. In my background, I was a medication safety officer for about 10 years. So pretty much on a daily basis, I worked with anyone involved in the process and was responsible for understanding how things went wrong and really trying to think about how to meaningfully fix problems. For the last 10 years, I've been faculty at the Johns Hopkins School of Nursing, where I teach pre-licensure pharmacology to undergraduate nurses as well as graduate nurses. And I'm also a patient safety specialist at the Armstrong Institute for Patient Safety and Quality. And I'm delighted to be here along with Mary. So this presentation is sponsored by the AMEE Patient Safety and Quality Improvement Special Interest Group. The group is a collaborative and welcoming community seeking to improve patient care by supporting the education of health professionals in patient safety and quality improvement. We encourage engagement, and we try to equip health professionals with resources and patient safety teaching skills that improve patient care. We are advancing tools and methods for assessing learner competency in patient safety and quality improvement. We embrace the use of mutual feedback to engage learners and educators. We are sharing existing and even developing new resources. We seek to inspire research to address gaps in patient safety and quality healthcare, quality education. And we also like to help and mentor each other in career development in patient safety and quality improvement. This is our Patient Safety SIG leadership team. Today we have Dr. Carice Knight with us, but we also have Dr. Yannick Eller and Dr. Robin Newton as part of that leadership team. And we would love for those of you on the call to join us. So what you see here is a QR code that you can use to express your interest in joining our Patient Safety SIG if you're interested. We have members from across the globe. We meet monthly. And as I said, we have a variety of different work groups to help us achieve our mission and vision. And so if you'd like to be part of that, we would love to have you. So for today, our objectives are to define the term human factors. After you complete the listening to this webinar, we hope that you can explain the components of systems engineering and patient safety model, or the SEPS model. We hope that you'll be able to discuss how human factors engineering principles can be utilized to improve medication safety, and also describe methods to teach human factors engineering to students, residents, and others. As far as disclosures, we have no relevant financial disclosures or conflicts of interest with the presented material in this lecture. So we're going to start off with just a little background on medication safety. Many of you on the call probably have seen some of these high-profile cases. These are, big cases from the headlines, mostly in the United States, but some of these cases, happen abroad, or maybe you recognize the patients from cases that are abroad. These cases go back as far as the 1980s, but if I looked harder, I probably could have found cases from the 60s and even earlier. One of the cases on here, the case of a chemotherapy overdose involved Betsy Lehman. This is really kind of the seminal case in the United States that really brought a lot of attention to patient safety. Betsy Lehman was given chemotherapy at 4 times the intended dose. In her case, she was given the 4-day course to be administered every day for 4 subsequent days. You also may recognize the Dennis Quaid twins. So Dennis Quaid is a popular actor in the United States. And so his twins, when they were in the ICU or in the neonatal ICU, they were given heparin 10,000 units per mil as an IV flush instead of the intended amount of 10 units per mil. There are several cases on here that involve neuromuscular blockers. So the case of Loretta McPherson, a case out of New York, a case that involves a patient, Charlene Murphy. We don't hear her name a lot. Usually when we hear about the Charlene Murphy case, we actually hear about the nurse that was involved, Redonda Vaught. In that particular case, the patient was supposed to get midazolam because the patient was going in for into radiology for a scan, and she was very nervous. And so some IV midazolam or Versed, which is the brand name in the US, was ordered. And unfortunately, what was removed from the automated dispensing cabinet or the electronic cabinet where medications are stored was vecuronium, which is a paralyzing agent. So in those 3 cases, paralyzing agents, and actually in a 4th case for a patient in Philadelphia, they all got a paralyzing agent when they were supposed to get a different medication. And all of those patients were unvented. So clearly the consequences were dire. Another case, this one is actually from Europe. In that case, a patient received vincristine intrathecally, but that vincristine was supposed to be given via the IV route. And so, medication errors like these have been happening for a long time. When I was in pharmacy school, I heard about some of these errors. And as I now teach nursing students, as well as pharmacy students and medical students and public health students, unfortunately, I still see some of these errors happening. And I, pull these headlines and add them to this slide. Unfortunately, I think we've made some progress in improving the safety of our systems, but we certainly have a long ways to go. I always stop here and, kind of think about the fact that we hear a lot about these high profile cases, maybe even, in our everyday life, we talk about them. But we aren't necessarily talking about just the vast number of medication errors that are occurring. I think in large part, this has to do with kind of varying definitions. This definition is from the National Coordinating Council for Medication Error Reporting and Prevention, which is part of the United States Pharmacopoeia here in the United States. And really, anything that's preventable. So a medication error is just a preventable event that can cause or lead to inappropriate use or patient harm related to medication use. And these errors are, intercepted all the time before causing harm. Those errors actually can provide us very valuable information about how the system's functioning and the risks within it. Unfortunately, though, we don't always hear about those as frequently as we do some of those high-profile cases that I shared. Medication errors are actually quite common. It's estimated that more than 7 million people in the United States each year are impacted by medication errors. It's estimated that 10% of hospitalized patients in the US experience a medication error. 1.3 million people every year are injured, kind of across all settings. And we spend upwards of $40 billion a year on patients affected by medication errors. And thinking of this globally, the World Health Organization estimates that the global cost of errors is almost 1% of the total global health expenditure. So we have a lot of room for improvement. Looking across the medication use process, you can imagine I talked about different errors and high profile errors. And when we dig into the details of those errors, they happen at any part of the process. Sometimes they're errors that, get through multiple parts of the process, and, kind of that last step of medication administration, that's really what we focus on. But, maybe we fail to focus on all the different upstream kind of effects. And really, I think what it comes down to when we think about the medication use process is it's very complex. It involves interactions of multiple systems made up of people, equipment, tools, technologies, variable tasks, different environments with which, these tasks are occurring. And then, of course, overlaid on that is culture. You know, how do we do things around here in that particular environment, but just kind of broadly? Culture has a huge impact on kind of the way we do things. When errors occur, it's really easy to say the person should have done this, or it's really easy to say, it's, Redonda-Vault, for example, that it's Redonda-Vault's fault that that error occurred. The problem is many times the error itself is really out of the direct control of the person. And in probably so many cases, we don't hear about the cases where that person figured out what was about to go wrong and corrected it before it got to the patient. I think the problem with, our kind of complex system is it's really easy to kind of place blame on that end user, that last person that, committed an error. It's really a lot harder to consider the maybe not so obvious factors that result from all the interactions of the system's components that lead to that final person making that mistake. You can see there are, just this diagram alone has 6 steps on it. And really, this is very high level. If we kind of look into the detail, there are, maybe 100 different steps where things could go wrong. And from the point of considering giving a medication to a person all the way to actually delivering that person. And so many different opportunities and so many different interactions between people, between systems. And again, all these interactions influence how that work is carried out and the likelihood of us achieving that desired outcome. So thinking of things like high-risk populations, like neonates, these babies don't have extra reserve when an error does occur. So, all the problems that occur, when we get into certain populations, the risk of a problem is even higher, or even scenarios. Think of transitions and looking at this diagram of prescribing and transcribing and dispensing, administering, monitoring. Think of all the different opportunities for things to go wrong, just on the level of communication itself, but also things like decision-making and access to information. And then, of course, if you think back to those errors that I shared, all of those errors, the ones that cause harm to patients, tend to be those that we call high alert medications. So these medications where there really just isn't a lot of margin for error. If something goes wrong, it's going to be harmful to the patient. So medication errors, especially those with catastrophic consequences, all too frequently we assign a single person that blame. But by considering these errors at a systems level, we can really take significant steps towards improving patient safety. What you see here is the hierarchy of effectiveness. This is a great guide. By the way, there are lots of different versions of this. This is just the one that I happen to like. This is from the IS&P Canada group. But as you can see, the least effective things that we can do are strategies that involve kind of making the person less human, right? Trying to make them more perfect or less fallible. These types of interventions involve education or providing information or double checks. You may be writing more rules and policies. Now, to be clear, education is important, but when it's the only thing we do, it's not going to be a highly effective strategy, right? Better approaches are going to be up here in this kind of systems-based category, where we're, maybe simplifying and standardizing, but doing it well, right? All simplification and all standardization doesn't necessarily get us where we need to be. Or we're automating systems that, are highly error prone when done manually by people. Or even better, incorporating forcing functions into the process that guide the right way of doing things. This is really a better approach, and really focus on building systems that support people to do their best work. If the system is designed in such a way that it can only be done the right way, this is going to help people and make it much less likely that people are going to do the wrong thing. So making it easy to do the right thing, or simplifying the work, reducing that mental workload. These are all, really, if you step back and think about it, that's all related to design and how we design the work. One of my favorite sayings is safety lives in systems changes. One of my previous mentors taught me that, and I really think that that's the key to all of this. So, we can't change the human condition, but we can change the conditions under which the human works. This is a popular quote from James Reason that really kind of summarizes that point. So it's all about strengthening systems. The problem is this is hard work, right? It's much easier to tell people to be careful. It's a lot harder to really think about kind of this holistic approach. This approach does not come naturally to people or to humans, right? And in some scenarios, it's not really that well defined, and it's certainly not routinely practiced in healthcare. And unfortunately, like I said, people, kind of our natural default is to look at a situation and kind of reduce out or strip out the complexity of that situation and kind of create these linear cause and effect chains. And it's really easy, to kind of point at that person that makes a mistake. But we've got to go beyond that, right? Systems thinking is a discipline that helps us do that, recognizes multi-directional causes and effects, kind of balances reductionist thinking, kind of that simplification, with holistic thinking, and really being able to see kind of the whole and the interdependencies and the component parts in that whole, kind of in that whole process. And, ultimately, systems thinking, really the goal of systems thinking is to enable people to do their best work by designing systems that support people. So I think, we tend to react, right? We look at an event and we react and kind of blame a person or maybe change a small component of that system, but we've got to dig deeper, right? We've got to anticipate, kind of, because of the way that the work is designed, we got to anticipate how people will interact within that system, and really change the structures of the system and the mental models of the people that are working within that system. So Mary.
Yes. So this photograph, interestingly, is it might be from baddesign.com, but I swear I went to a hotel where this was the entrance into the parking structure, and people would get into this. They'd pull the door open, they'd get in there, and then they try to pull the next door, and it didn't work. Well, it looks like it's locked. So then you turn around and try to pull the one that's up front again, and they would just get trapped. This is not a good thing if there was a fire, for example. So it's because the handles on the door don't tell the person what to do. They give them too many choices. So this is a really good example of a symptom of bad design. And so other things that you have, and I always say that once you start learning about human factors engineering, your life is never quite the same. You're taking pictures of things in hotels. You're looking at kitchen implements differently. Everything about you changes because you realize what an important part design is in living effectively and safely. So if your device is non-intuitive, my gear shift, 30 years, I pushed my SUV gear shift up to park. It's not there in my newer car. It's in the middle. And people, when they get, they have the muscle memory and it is not in this place they're expecting it. I mean, they've had people pinned up against the fence. There was a person who was killed by this. So these things are pretty serious. So if it's hard to remember something, if you have to constantly retrain, I bought a $10,000 piece of packaging equipment early in my career. It was so cool. It was made all these little liquid cups. I just thought that was the coolest thing ever. And I walk by and the technicians are using a syringe to fill the liquid cups. And I'm like, what are you doing that for? they could never stay well enough trained to use the fancy piece of equipment, which we ended up selling for scrap metal. And that happens more than we care to admit. If there's situations with look-alike, I mean, we've got lots of photos, what looks like milk versus a bottle of glue. I mean, there's lots of those things, and shampoo in a hotel, they all look the same. If you can't tell what something is doing, if like you're in software or you're using a device and it doesn't tell you where you're at, right? You can't, you lose, you get lost in the automation, so they say. And if the alarms aren't helpful, like I back my car out of the garage, I have 3 and 4 little ding, ding, ding going at the same time. I still am not sure which goes to which. You know, I know what to watch on the dashboard, but it's annoying rather than helpful. So that's fairly common. And if you get things that are repeated or tedious, and I think of the electronic health record, how many clicks does it take to get somewhere in the EHR versus some of the older systems that were so fast because they were, you could jump around and you could be expert level and do things differently than the novice level. And if, you know, if errors are difficult to find, it's not conspicuous. And if you need a lot of workarounds. So a colleague of mine who works in informatics said, I walk into a medical unit or into the pharmacy and I look for the sticky notes, like how many sticky notes, and it's just as bad as before the computer upgrade. Next slide. So what could go wrong? Well, we had this new bag system, and there's multiple kinds. There's the Advantage bag, and then there's, you know, I forget even the name of the Baxter one, Mix-a-Vial or something. And this was pretty cool because you could put these together in the pharmacy and then put them in the night drug cabinet, put them in floor stock, and they weren't activated till right before you needed them. And I remember in the 1990s, I came in on a holiday weekend to see just how many patients were getting therapeutic doses of 5% dextrose in water with no drug, because you have to remember to activate the drug before you infuse that little piggyback. So what could go wrong? That was not the greatest design. It was great in stability and great in simplicity. But for the busiest person in healthcare, the bedside nurse, it did create issues that it could easily be skipped by accident. Next slide. So, human factors engineering. Now, the first thing I want to say about this is I hear people, and I travel all over the country, I hear people talk about the human factor, like blame the human. That's not human factors engineering. Next slide. So what is it? Well, I do a lot of speaking on safety topics, and the best thing I can say is it's kind of a cross between engineering and psychology. You know, sometimes people end up talking about ergonomics. That's also a big part of human factors. But there are multiple kinds of human factors engineers, and you know, it's basically a discipline in science about designing around the human, designing to make it easy to do the right thing and harder to do the wrong thing. So it's a whole discipline in and of itself. And we say, and this is Nicole's favorite thing that I say, is that it's the core science of patient safety. You would no sooner have somebody work in infection control that didn't have microbiology, at least some background, than you would put a safety person without some training in human factors. Yet, it is not that well known in some of the health professional disciplines. That's unfortunate. But we like to think, you know, what is it that works to make sure that the brain of the person doing the task is set up for success? Because if you look at events week after week after week, you look, how could they not have seen this? Well, these are easily explained by some of the human factors issues. Next slide. So they're everywhere. This is what I say as you go, like, especially if you travel, refrigerators that open the wrong way if you're in the breakfast buffet at the Marriott Hotel and it bangs into the wall. And, we're especially bad with creeping featureism with cell phones and video equipment and all those, gaming things and all that. It's really good for somebody with a younger brain that grew up with that. But if you look at people who might have hearing or visual problems, these are not that easy to use. And Nicole was explaining that, how is it that you can put locks on there, the parental controls, and it's not so easy to do that. And I recently had some kind of the little strip that tells you how high your phone is, how the volume. I couldn't get that thing to go away. And it was like over most of the screen. So it seems easy, but it's not easy. And you have to be persistent. So these things, they're just over featurized and undersimplified. Alarm clocks. I never use the alarm clock in a hotel because I have no guarantee that it would actually ring at the right time. We have done studies on entrances to the buildings and parking lots. Believe it or not, a lot of people get injured. They get pinned in the door. You can't walk fast enough for the turnstile. You trip over the parking block. There's potholes in the parking lot, etc. So there's a lot of injury outside the hospital or ambulatory care. And I've been in many, many rental cars. My favorite one was the window, up, down on the window. Wouldn't you think it would be on the door? Where I think about it. Or it could be on the console. And this one was in the dash. I think that was a PT Cruiser some years ago. And I'm like, it has to have window controls. Where did they go? So when you go out of the little booth, I couldn't get the window to go down. So I had to open the door to give my little rental agreement to the dude in the booth. So this shouldn't be this difficult, but it is really true. And then wayfinding. People get lost. They get lost in the hospital. They get lost in airport terminals, and it isn't always very well designed. And my most recent thing is e-prescribing. It could be more legible, but is it correct? And is it telling you the right thing? We had people send the e-prescription over, one red tablet, TID. I mean, really? You couldn't find the drug name? So, or they go to the wrong pharmacy because they picked the wrong patient because the patient identification part is incorrect. And in fact, my medical record has somebody else's records commingled. So these are complexity and design issues. The next slide. So what do we do with HFE in healthcare? So we use it in all different ways. So we know that if it's a difficult system, it causes stress for the people using the system. So you get provider burnout. Like if you're going to implement a new computer system, you can guarantee one of the reasons you need extra staff is to keep people from getting too burned out. It also helps you fail to safe or minimize the consequence of error. If you're going to have, for example, concentrated insulin, maybe don't put that in the regular drug file. Maybe make somebody get a concentrated insulin pathway or whatever, so that it makes it that we have all the checks and balances in there. You can use human factors to improve training, like Nicole said. And you can also look at, what is it about the health technology, that can be built around what the human is expecting, as opposed to like bizarre things. I remember one computer system we went to visit, and they had there was the cutest little thing, had all these little IV bags for the piggybacks, and so you could see the piggies and you could see the large volume and the little bottles for prescriptions. but it was cluttered and not well done. So I think they were attempting to make it good design, and they actually made it worse. And then if you have well-designed processes for communication, that can enhance things. So we have been trying to get people to train through bad design, and you cannot train your way out of bad design because your brain flips back to accidental, to doing it another way. Like if you go on vacation, you know, when I come back from vacation, I can't remember any of my passcodes if it's a good vacation. So the same thing happens if it's really complicated. If you got to have a 10-step checklist to put an order in, there's something wrong with that. Nicole?
All right. So thinking about human factors and how it can be helpful, it's really useful to understand some of the human factors theories. Now, clearly, we're going to scratch the surface here, and some of you, even some of you on this call, are probably experts in this. But we're just going to talk about what is it about people that makes some of these things really difficult. Um, you know, like Mary said, so often when we hear, the human factor, we hear people talking about, how people fail, or, it's really kind of like another way for blaming people. But really what it comes down to is it's the way people think. It's the way our bodies, spatially interact with our environment. A lot of that, especially with the cognitive ergonomics, a lot of that is really kind of evolutionary, right? So, if we encounter information, we've got to process that information quickly, especially, if it's something we do all the time. If we had to think through the 20 steps to, actually open the car door, we probably wouldn't get out of our house or get to work on any given day, right? So our brain has these shortcuts, and those shortcuts help us in most scenarios. But, depending on the design of the system, depending on the complexity of the process, those shortcuts can be problematic. So as Mary mentioned, human factors is really the science of improving human performance. It emphasizes these different interactions between people with each other, right? And those people have inherent cognitive, physical, psychosocial abilities and limitations. And so human factors emphasizes really maximizing those capabilities and minimizing those limitations, all within this socio-technical work system, right? Which is the person plus all the technology and the tools and tasks and the physical environment and the kind of culture with which they're working. So what we're suggesting is that systems should be designed to meet the needs of humans. We know cognitive and perceptive capabilities. We know cognitive and perceptive limitations that people have. We know people have limits on how much they can remember at any given time, on how long they can remain alert at a task. For example, when I was working in the pharmacy, we kind of had the work organized such that I would be reviewing orders, for 4 straight hours, and then take a break for lunch. And then I'd come back in the afternoon and I would check orders for 4 straight hours, and then I would go home, right? And so, how long someone can maintain alertness, this is known information, and we know that, that ability to do that degrades over time. And so it's important to design the tasks to really maximize that. We know people have, limitations in their ability to differentiate objects or colors or shapes or even words. And even things like lighting levels can influence this. There are physical limitations, so strength or endurance limitations. One that I always think about is kind of the kind of repetitive motions. Again, when I worked in the pharmacy as a medication safety officer, I noticed we had a lot of technicians out for repetitive injury errors. And again, we had their work designed in such a way where they were drawing up meds manually using one hand to hold a product and the other hand to kind of pull very forcefully against a syringe when they were, drawing up medications. And that was leading to some of those errors that, or some of those problems that we were seeing. So, thinking about the cognitive limitations and really minimizing those, or the physical limitations, as well as what are the capabilities and how do we maximize those? And then, kind of beyond those human aspects, it's really like looking at the optimization of the socio-technical system. So that person with all of their inherent capabilities and limitations working kind of within that broader system. Interacting with tools and technology, interacting with other people, carrying out tasks and how those tasks are designed. Are they designed to optimize those capabilities, or, are they really not addressing at all those limitations in the organization and the environment, and like ultimately designing systems to meet the needs of users? So, we know based on engineering, human factors engineering and psychology engineering, design, and other aspects of engineering, we know what those capabilities are. We know that, for example, people tend to be better at perceiving trends when it's presented graphically, or people are able to kind of spatially locate auditory or visual signals. From a cognition standpoint, they're able to understand complex relationships and make diagnoses, ability to troubleshoot. Even from a physical perspective, able to learn and carry out complex sequences, and even with like motor tasks. And so really accentuating and optimizing these factors is important. We're going to do a quick test here just to see how you all do at this. So use your chat. And what I want you to do is look at this list of labs. And when you know how many labs are out of range, put a 1 in the chat box. So go ahead, start right now. I'll give you a few seconds to do this. But once you're able to find the answer, put that in the chat. Okay, I see some ones coming in, still some people working on this. And by the way, while you're typing your ones, this is one of my favorite examples. I first learned of this example from a human factors engineer I worked with named Nana Kunlerkit. She was a human factors engineer at Hopkins when I first started as a patient safety specialist. All right, so it looks like most people have got their information in. So the reason why I like to do this is it took the first person put the information in at around 25 seconds, and the last person put the information in at around 45 seconds. So in terms of how long it takes, I guess my next question is, how easy was that? And, was it easy? Was it a difficult task? Was it an easy task? Did you like doing this task? Would you rather not do this task if you didn't have to? These are all some of the important questions. Now, I'm going to advance to the next slide, and I'm going to ask you to do the same thing. Type a 1, or actually maybe even type a 2 into the chat when you find the answer in the next example. So how many of these results are out of range? Yeah, so almost instantly we get responses. So usually within 5 seconds. And again, the point here is that from a perception standpoint, or even a cognition standpoint, if you look at the human limitations, when there's no contrast, or when, the information's not differentiated, or if there are, if you have to remember information, like in that example, you had to remember information and carry it forward as you went through each of those test levels. You had to remember, and at the end kind of calculate after looking at 6 different labs or 8 different labs, and figure out, how many were out of range. And really that process of integrating that information from kind of different sources, we're not necessarily good at this unless we design the interface in such a way that, assists us in that process. So other things like inattentional blindness. Inattentional blindness is, where we're, our failure to recognize certain pieces of information when we're looking for other pieces of information. And so we have a quick example on this.
The monkey business illusion. Count how many times the players wearing white pass the ball. The correct answer is 16 passes. Did you spot the gorilla? For people who haven't seen or heard about a video like this before, about half miss the gorilla. If you knew about the gorilla, you probably saw it. But did you notice the curtain changing color or the player on the black team leaving the game? Let's rewind and watch it again. Here comes the gorilla, and there goes a player, and the curtain is changing from red to gold.
And why is this?
When you're looking
right?
for a gorilla, you often miss other.
Right. You miss other things. And the reason that the narrator asked you to look at the white shirts is to get you distracted from the black shirts and the gorilla being black. But this curtain changing color, that's a new one. I've used this video a lot, the general concept, and never seen the one. And I just saw it again and I didn't even notice. It's so out of my frame of reference, right?
Yeah, so going back to those limitations of perception and the impact of, our focus being on one thing, but not seeing kind of those other things that are happening. I think another example of this, this is a real case from my hospital, one that I was involved in investigating. We had an anesthesiologist who mid-case was giving a redose of cefazolin and actually gave vecuronium instead. And when we talked to, and it was recognized, fortunately, because of the environment, the patient did fine. But you can imagine if that had happened somewhere else where, the airway wasn't actively being managed, could be really problematic. And so when we looked at the vials, we realized, well, wow, they do look very similar. And furthermore, as a pharmacist, I know that, and both myself and the anesthesiologist said, well, wait, this usually has some lettering on it that says paralytic, but it's missing. But when we looked in our stock, we did have some that actually did have that lettering. And so, sometimes differentiation, like in this scenario, can be very helpful. But, it's not always the be all end all, right? I'm sure you've all heard of this high profile case involving a nurse. This is the actual medication vial that the nurse used. She gave vecuronium, which is a paralytic agent, instead of midazolam, which is brand name Versed. She was removing the medication from an automated dispensing cabinet, which is just, if you don't have them where you are, just a machine where has an interface and, you can remove the medication. This particular medication, she was looking it up on the patient's profile for Versed, and couldn't find it. So went to the override mode and typed in VE and found the first thing that popped up on the list was vecuronium. And because we use multiple different names for the same medication, just assumed that that was the right name, ultimately gave the medication to the patient who was unvented, awaiting a scan in the MRI suite, radiology suite. And that patient did not make it. And so, the kind of question here is, just differentiating products, is that enough? Really what we need to do is step back and look at the socio-technical system. So looking at those interfaces, right? The interface between the person and other people, the person and the technology, like in this case, the electronic order had been placed, but when it flowed over to that dispensing system, it wasn't easy to find. In fact, when this nurse went to give this medication in the radiology suite, there was no barcode scanning even in effect. So even though the nurse almost always used the barcode scanning to help facilitate that administration process, didn't do that in this case because it just wasn't available, right? You all may be asking yourselves, well, why was it so easy to get that medication out of the dispensing system? And so, looking at that, there really weren't alerts built into that system at the time. There was a very generic alert in place at that time that really just said like, yeah, you're overriding this med. Do you want to proceed? And so, how effective is an alert like that? We could talk about the environment itself. So this nurse was giving meds in an environment where she doesn't normally work. And then culturally, at the time, there was an implementation of a new electronic health record that was interfacing with the system where the meds were stored. And because there were so many issues with the flowing of that information from the EHR to the system, nurses were just encouraged to override because it was taking too long to wait for those orders to flow into the system. And so, looking at those kind of interactions at the person level, the interactions at the tools and technology, the environment, the organizational culture level, as well as the task itself is really important. And thinking through not just that like last step, but what are all of those steps? One thing that kind of I like to share here is at our institution, when this happened, we did a huge evaluation. And one of the things that is recommended by the Institute for Safe Medication practices in the US is displaying an interruptive alert that requires the purpose of the use of that medication and verification that the patient will be ventilated. So this is a very prominent organization that recommends this interruptive alert. But the problem for us was when we went to implement this alert, the technology that we had, what you see here was what that alert could possibly look like. We did get a lot of feedback from frontline users, and we, came up with the design you see here. But as you can imagine, there are lots of problems with this interruptive alert. I mean, I'll just point some of them out because, we're not able to have you all kind of call out some of the issues, but feel free to put some of your feedback about this alert in the chat. One of the things that when I ask people to look at this alert, the first thing they say is, well, wait a minute, it says, no, do not give this paralyzing drug, press skip. But it's green, and green is go, right? Green makes us think like that's what we're supposed to do. And this is, again, a limitation of the system. Whatever that first line is, it's automatically highlighted green. And we were reticent to kind of flip these around and put yes in the first one because people kind of tend to click whatever the first thing is on the screen. Furthermore, it's kind of confusing. It says press skip, but actually what the nurse needs to do is press one of these options and then press skip. And some of you may be asking, well, wait, what does skip mean? Does skip mean I can proceed through the alert? Does skip mean that it cancels me out? There really are so many issues with this alert. And when we started to look at actual data from what do nurses do when they encounter this alert, what we saw was really disappointing. Not that we're disappointed in the nurses, but we're really disappointed that this intervention that's highly recommended isn't achieving what we think it's achieving. So about more than half the time, the nurse that's removing the medication is clicking no. The patient, is not ventilated, but yet they're removing it anyway, right? 600 times versus the nurses that said yes. And then, that's slightly less than 50%. Either way, all of these nurses were able to remove the medication from the system. So this really signifies that while we think we're developing a good system, we've got a long ways to go. Mary.
Yes. So this is just a kind of an overview of the whole process. And these things happen in cycles, and it isn't like one and then the second one and the third one. So this could be you and the steering wheel on the car or the GPS that you're using. So these things go in a complete circle. And it is complicated. It is different inputs, different outputs. And so it isn't as simple as it seems. Next slide. Here's some examples of bad design, good design and bad design. The one on the left, obviously, you can't tell which knob goes to what, but the one on the right is a lot more intuitive. Next slide. And these are I put these in here. I love the pull on the, it's like a toaster or something. And it says, basically it encourages the user to put their finger in there to pull out the plug instead of yanking it by the wires. And they make this also in the United States. I have a toaster oven that uses that format. And then my all-time favorite ironing board that is designed better for the task. So if you need to iron pants, it goes one way. If you need to iron a shirt, it goes the other way. Next slide. And then this is a really award-winning design for prescription labels from Target, which since it got bought out by CVS, they stopped doing that, but it had patient information inside of the thing that's on the back of the bottle. So you could get all your stuff is in one place. Really, really good design. And remember the Advantage bag we had where if you don't activate it, it won't give you the drug. It'll just give you the diluent. This thing on the right is better designed, and the powder for the drug is below the liquid. So you can't infuse it without diluting the drug. So we think that's a really good design. Next slide.
Yeah, and so when you look at the good design, there are a couple things that kind of come up again and again. Keeping the design simple, right? Keeping it natural, having it match your mental model or kind of what you would expect in the real world. Making the system's functions and status obvious, right? So you can easily know what's going on. You've got feedback within the system to know how it's operating or whether something's gone wrong. One of the most important, minimizing reliance on user memory, right? So making relevant information apparent, making it obvious and easy to navigate, maybe automatically filling in fields, such as like units of measure, for example. Maintaining consistency and standardizing, so displays or labeling. Like Mary said, these are great ideas, making it consistent and standard, but it can be done the wrong way if it's not done simply and it's not done kind of naturally. So like that example that she used early on where there's lots of icons, but we don't know necessarily what those icons are. And furthermore, they're cluttering the system. Providing meaningful feedback to users. This I always think of like when I go to the gas pump and I press the buttons. If I don't feel anything, I kind of keep pushing and pushing until something happens. And, those kind of systems aren't giving good feedback. And most importantly, incorporating in error prevention. So fail-safe design, helping users recognize when things go wrong and recover from that before it becomes critical. So you all may be thinking, well, where can I use this in my practice? I think, first and foremost, it's really about teaching people to think like systems thinkers, using these concepts to help people become systems thinkers. Like in that, Vecuronium Versed error that I shared, really creating design that's user-centered. We can do this when we're analyzing errors prior to, buying new products, like infusion pumps, for example, during proactive risk assessments, anytime we've got to redesign a process or a system, even something as simple as a cognitive aid or instructions for how to, do something in your work environment. We can use these principles to help us test changes that we're considering, and just kind of designing anything in the healthcare environment. One common method that human factors engineers use is usability testing. I've been involved in a variety of different usability testing, and for me personally, this is absolutely one of my favorite things. So the aim of a usability test is to look at how people use a product and discover how errors can occur and where there are areas for improvements, really kind of analyzing. And then, developing a plan. So scenarios and tasks, what performance measures will we look at? Like how many errors occur or how long does it take to recover? What's the mental workload as part of that process? Recruiting end users to actually test the process and then delivering that or moderating that test and collecting data and figuring out where to go next. And Mary's going to share her story.
Real quickly, I walked into a hospital pharmacy and I saw a kind of a horrifically designed code cart, and I happened to like to cook. So I thought this could be a lot better. So we got university students. I contacted a plastics vendor and we used nurses from the ICU to do testing. Next slide. And so the original tray, we call that the lipstick method, where the lid is face up. And there were at one time 5 drugs had gray tops on them. Really bad idea. And it's not very amenable to if you have a drug shortage. So then the first prototype, we had these little channels we put the drugs in so that the label was face up, and we got rid of those tiny little labels because people would read that label instead of the drug. And then the final prototype after the second phase of this project winded up on the right. And we did nurses from the ICU, students, and we had multiple code scenarios and we put pressure on them, and we had a lot of learning from this. Next one. So one thing from this slide, this is a whole article that we did. We found out, we went back and looked at the videos. Only 35% of the time were people looking at the label on those vials that were in the lipstick tube format. So that was really bad. So next slide. So what we did with the redesign, we took this all over the hospital. We got feedback from nurses because it could have gone any way in terms of how we designed it. And we went in order of use. We looked back at code scenarios for like 6 months or a year. And the nurses absolutely loved it. And next slide. So the vendor ended up really improving it. So he made the vial grippers, and he also made the alternative one on the right, which is looks like a flip-flop. And he sent me a heat map of the places they've sold these, and I think it's up to 43 countries now. And so it really helped and forced to read the label. Next slide. So it was a small hospital and we didn't have any resources. We were under construction, but we still did it anyway. We still tested this and we used outside resources. We ended up using some industrial engineering students from the local university to help us in phase 1. And we had the staff help us. They had hidden skills we didn't even know about. So it was very cool. And they did the videos just on their cell phones. And so, it has been really rewarding, and it's still in use today. Next slide, I'll show you the village. So those are these were our pharmacy interns in the center. And then we had 2 sets of pharmacy interns, the nurse manager, the industrial engineers, the vendor, and the videographer, one of the volunteer techs. And we got an award from the American Society for Health System Pharmacists. The vendor is in the jacket. He's a Marine veteran because it was a veteran-owned small business. Next slide.
All right. So how would you use this for teaching others? I guess, first and foremost, encouraging systems thinking. So utilizing real world cases, conducting seminars on systems thinking where students can actually practice and apply the tools. implementing interactive simulations. And I know I saw some of the folks on the call, and I know some of y'all are using highly interactive simulations to help students learn new skills, but then build into those simulations how things can go wrong. Fostering interprofessional and interdisciplinary collaboration. So encouraging and introducing opportunities for students to work together, not just students, practicing clinicians as well, but especially students. So before they're getting out into the work environment, and really kind of emphasizing problem solving through the systems lens. We have a program at the school where I teach called the Health System Sciences Interprofessional Scholars Program. This program utilizes the Health System Sciences framework, and it is a program designed for pre-licensure nursing students, but we have medical students, medical residents, as well as pharmacy students that interact or participate in this program at different points. It's a 2-semester program. Some of it is asynchronous content like recorded videos. A lot of it is live seminars, either in person or on Zoom. And we have a wide variety of experiential activities. Our ultimate goal, though, is to create system citizens. So these are people who recognize that it's their job to be a systems thinker and to engage in redeveloping and redesigning the work that we all do so that it supports people to do the best they can. This is just an overview of the different seminars and experiential activities, but you can see one of our seminars is a human factors engineering seminar. We teach the students about improvement strategies and solutions. We have the students, they actually are on a unit-based safety team throughout the semester. They do a lot of shadowing, and they do an interprofessional case. The seminar itself, there are didactic components. We're lucky we have several human factors engineers. So the human factors engineers actually come to our course and teach our students, which is just fantastic. They do a case study with our students, and we have some application exercises as well. The case study that we do is on vincristine administration, accidental intrathecal vincristine administration. So we have a discussion around this case, real live examples, hundreds of reported cases of this. We have the students consider the cognitive and physical ergonomic principles and how they relate to this case. We have them consider the socio-technical system. We start off with kind of the traditional dispensing. We talk about, how might mini bag dispensing of this product improve the scenario, and really what are the risks even with that. And the students almost inevitably come up to this idea that we need different connectors, a LOR connector, and then, a connector that's only for intrathecal catheters. The other thing we do with the students is some active learning exercises where we actually have them conduct a heuristic evaluation. So we provide them with like Nielsen's heuristics, and then we have them evaluate prescription bottles. We do this exercise also in our human factors workshop where we teach clinicians. The final thing, very, very quickly, is that we group the students together in small groups. We give them high profile cases, and we have nursing pharmacy students work together, and we pair them with medical residents, and they work through a medication error case, evaluating kind of every step of that case, how, what kind of questions do they have for the people involved. They construct a flow diagram. They use different methods to help, like cause and effect analysis, to help them figure out how did this kind of fail. And then they apply systems thinking and human factors knowledge to design solutions. And that's just one of the 2 courses that are part of that. In the end, we use the systems thinking scale. We use pre and post tests kind of approach to evaluate that process. Outside of my program, we also do something similar at the medical school here at Hopkins. I did not design this program, but I do teach in this program where we have a 3-day live course for our medical students in their 2nd year. And again, they go through various types of training, including human factors training. They do case discussions, they do simulations, all really with kind of a focus on systems thinking. And they do show statistically significant increase in self-efficacy in these concepts, as well as systems thinking using the systems thinking scale. Other examples, this is just an example I came across from India that kind of follows a similar model. And so the reference is there. And of course, after the presentation, we'll provide you all with the slides. Kind of bottom line, I think it's really important to raise clinical awareness amongst clinicians, educate faculty and students, and it can be done. We are doing it, and lots of others are doing it. But I think the last thing I'll say here is like really partnering with your human factors experts. I'm lucky where I work, we have some human factors experts on staff. And like in Mary's example, she partnered with a local engineering school to bring those engineering experts into her project. And so, you know, really, ultimately, real safety improvements require health staff, leaders, and decision makers at all levels to develop systems thinking competencies and behaviors. And so we've got to start with educating folks on these principles. One last plug for our patient safety and quality interest group. So again, if you're interested in getting involved in our group, we'd love to have you join. And so I know we're just a couple minutes over. I don't know if we have any answers, Q&A questions.
I answered a couple questions.
Okay.
Do you have any advice for usability tests in the work environment? And I just said to get permission from supervisors and make it as lifelike as possible, and be careful not to use fake stuff, because the real products are safer because they're labeled. And, you know, we've had some fatalities that have happened by using simulation meds by accident, right?
Yeah. One of the questions was there an overall increase in cost for the code cart conversion?
Nope. And we got rid of one, went from 2 trays down to 1 tray. I mean, it costs a little teeny bit, but the plastic trays were nothing. And that's why we didn't implement the prototype. It was like $50 for this really clunky prototype. But then they took it back to the shop and figured out how to be way smarter about it. And that's when we got the silicone grippers. That was cheap. They're like 10 cents or something.
We also just recently implemented this model at Johns Hopkins Health System, which is where I work in the United States, and very well received across our various hospitals. One other question was, one of the complex scenarios is patients with multiple meds at home. Do you have any successful experience ensuring they get the correct med at the right time? Patients are also challenged with needing med rec after admission. Mary, did you want to comment on that? I have some ideas as well.
Right. In the health system where I work, we have home-based primary care pharmacists that go into the home, and they look in the medicine cabinet and they look around the kitchen. They kind of suss out various safety hazards. And I believe mostly the nursing staff help. The pharmacist can get it started, but the nursing staff that visit every week, they do a med box fill. And we've also had some luck with compliance packaging that comes out of a strip packer. I had that program going for a while, but that's expensive and the computer system didn't support it very well.
Yeah, I agree. We have something similar where within 48 hours of discharge, we have a team of nurses. Unfortunately, Dimitri, we don't have this across all of our service lines. With our highest risk service line, especially those with multiple meds at home, we have a team that makes phone calls to patients and talks to them after they've left the hospital. Talks to them about, do they understand the discharge? We do a lot of teach back in that process as well. We don't, to my knowledge, we don't have pharmacists that go into the home, but we do have nursing and part of our home care team. So for those patients where it's identified that they need additional assistance, they can be referred to the home care team.
Right. As far as med rec, it's, we tongue in cheek, it's spelled with a W because it is so difficult. But we have a couple hospitals have implemented a different kind of software that integrates and is a little bit easier for the providers. But when we converted to a national software versus our custom made homegrown system, the numbers plummeted because they still haven't figured out a good way to do that, but we're working on it.
Elizabeth asked, what tests do you have to assess the level of systems thinking ability? One test that we use is the systems thinking scale. And it is a validated survey. I just put a quick link in the chat that I could find, but when we, I believe we're going to send out the slides, we'll have the reference on the slides for that as well. Any other questions? I think we got them all. Catherine or Davina, were there any questions in the Q&A? And it looks like they were answered. Okay.
I was busy in the background.
Nice, wonderful. All right, well, thank you, everyone. I mean, we could continue talking for hours, but we're 11 minutes over, so we do really appreciate you staying on. And yeah, we hope that you know, when you go back into your environment, you're going to identify safety hazards. You're going to communicate those to the people who need to make changes. And if you want to learn more about human factors, there are a wide variety of workshops and conferences. You know, we're both in the US, so there are, you know, through the VA, through Johns Hopkins, and through other organizations. But I know in Europe, there are lots of organizations that provide human factors training and education as well for clinicians like all of us who, you know, aren't engineers. My last plug, because I know that one of my human factors engineers that I work with is on the call. It's so important to partner with our engineering colleagues. We think of interprofessional collaborative practice, but I don't know, you know, the last time I talked to just a regular doctor or nurse or pharmacist, they weren't thinking about engineers. And I think that needs to be like a core component. We need to be thinking about how can we integrate engineers, you know, into our processes to help us design work that really supports our healthcare clinicians to do their best work.
All part of high reliability.
Yeah.
Yep.
So thank you all so much for being here, and we look forward to interacting with you all in the future.
Thank you.
Thank you.